Good evening to all. So we'll be starting with endophthalmitis versus uveitis, how to differentiate it. So endophthalmitis is intraocular infection affecting the inner coats of the eye associated with significant progressive vitreous inflammation, and it is ophthalmic emergency that can result in devastating ocular and systemic complications. Whereas uveitis is intraocular inflammation primarily affecting the uveal tract, and although adjacent ocular tissues like retina, vitreous, and optic nerve may also be involved. So endophthalmitis can be exogenous, where the common route of entry of infective organism is through an external wound of entry caused by trauma, surgery, or infected cornea. And endogenous endophthalmitis occurs due to hematogenous spread of microorganisms from the distant foci. And this is the one which often mimics uveitis. So why this diagnostic dilemma exists? First of all, the patients of both of these entities will present with redness, pain, photophobia, and visual disturbances. And they might have common presenting signs such as anterior chamber cells, flare, hypopyon, and fibrin. Fundus features like severe vitritis, subretinal abscess can be seen in both of them. Exudates are more common in endophthalmitis, and retinitis in periphery is more in favor of viral etiology. Vascular sheathing and hemorrhages can again be seen in both. So to differentiate, first comes the importance of history. Endophthalmitis, it is important to know the history of immunosuppression, neutropenia, history of fever, urinary tract infection, organ transplant, intravenous drug abuse, indwelling catheters, diabetes, hemodialysis, cardiac disease, malignancy, and any recent intraocular surgery or trauma. Whereas for uveitis, we need to know whether there were any previous episodes of redness or pain, systemic associations like back pain, oral or genital ulcers, herpetic encephalitis, contact with TB, and skin lesions. So coming on to clinical findings. So according to this study, ocular signs suggestive of endophthalmitis were uveal tissue abscesses, hypopyon more than 1.5 mm, vitreous exudates, visible arteriolar septic emboli, necrotizing retinitis, perivascular hemorrhages with inflammatory infiltrates, panophthalmitis, corneal infiltrates or ulcer. So the common presenting sign in both of these entities is hypopyon. And when is it misleading? So HLA-B27 associated uveitis and Behçet's disease usually present as hypopyon uveitis. Flat top and shifting hypopyon is commonly seen in Behçet uveitis, but it can be seen in very early and rapidly progressive infectious endophthalmitis in which sufficient fibrin has not formed to mold the upper edge of the hypopyon. Similarly, sterile endophthalmitis from intravitreal injection or triamcinolone acetonide or from oral administration of rifabutin can also present non-infectious hypopyon. Next common sign is vitritis. Presence of only anterior chamber inflammation is less likely to be endophthalmitis unless it is early presentation or there is limited exogenous endophthalmitis with an anterior entry or keratitis. Vitritis may be minimal in intracapsular delayed endophthalmitis leading to misdiagnosis. And to quote a case example for this.
Good evening, everyone. Case 1, a 39-year-old male presented with a history of cataract surgery 5 months back in the right eye. He had history of recurrent redness and pain in the right eye for 4 months and defective vision in the right eye for 3 months. He was treated elsewhere as a post-operative inflammation with topical and systemic steroids. Considering the non-response of the treatment, he underwent simultaneously for the uveitis workup for TB and sarcoid. It came out as negative. So on presentation, his visual acuity in the right eye was 6/7.5 and slit lamp photo is there. It is showing a mild circumcorneal congestion and cornea, like there is a pigmentary capes like large clumps deposits on the endothelium, and AC showing a flare of 3+ with cells could not be appreciated. And behind the IOL there is a grayish block noted in the inferior edge of IOL, and AVF is not appreciated. In ASOCT, it shows a hyper-reflective dots on the endothelium and IOL placed in the bag and well centered, and there is no infective foci behind the IOL in the visible frames. This is the fundus picture showing a media haze in the right eye. and for maybe it is a low grade endophthalmitis or low grade inflammation. So we did the AC tap. It showed a positive for eubacteria for gram positive cocci grown in the culture. So treated with intracameral moxifloxacin injection in the back. So it's a post-surgical inflammation, usually is acute or chronic. Acute is less than 6 weeks. If it is within 12 hours, we can suspect a toxic anterior segment syndrome. And it is 12 to 48 hours, we can suspect endophthalmitis or retained lens fragments or exacerbation of uveitis. In case of chronic cases like more than 6 weeks, can be a retained lens fragments or malposition IOL. It can cause the chronic rubbing with the iris and pigment release, and it can cause a chronic inflammation, and could be a delayed onset endophthalmitis or new onset uveitis. So most cases are acute onset and fulminant to begin with. In endogenous endoph, especially with fungal infection like candida, the onset may be subacute and can resemble the posterior uveitis or intermediate uveitis. So another case is like 21-year-old male with Hodgkin lymphoma post bone marrow transplant and chemotherapy, presented with sudden onset right eye defective vision and redness, and he had history of fever and upper respiratory infection for 5 days, and elsewhere he was diagnosed as a severe vitritis with frosted branch angiitis, and in blood CMV DNA PCR was positive with CD4 count of 38 cells per microliter, and he had a perianal abscess. It showed a protease growth, and he is suspected to have a CMV retinitis or endogenous candida endophthalmitis. So he has empirically started on antiviral and antifungal therapy. So this is the fundus picture showing exudates in the exudate suggestive more favor of endophthalmitis, and he was advised lensectomy with vitrectomy plus intravitreal antibiotics and antifungals. This is a B scan showing more of vitreous echoes with attached retina, more of membranous and clump echo. These are confusing scenarios like with case 1, 51-year-old male presented with a history of insect fall in the right eye. Elsewhere noted to have endophthalmitis with hypopion with no history pertinent to uveitis, and he had nil systemic history. And visual acuity in the left eye was hand movements. On examination, cornea showed a diffuse DM folds with fibrin in the AC and pigmentary deposits along the inferior angle of AC, and posterior synechiae with yellow glow fundus was noted. So we did a AC tap. It came positive for varicella zoster virus, and blood and urine culture were negative, and the culture was negative for bacteria and fungi. So patient was treated for viral uveitis like with oral valsivir. This is the case of 42-year-old male with a known case of choroiditis. He presented with the total cataract in the left eye. He underwent cataract surgery. At POD4, he had AC reaction cells plus and fibrin over the IOL. There was no red glow. The inflammation was more than the expected during the post-op day 4. So we suspected to have a reactivation of uveitis or endophthalmitis. This is a slit lamp picture of the patient showing a circumciliary congestion with the DM folds, and a B scan showing vitreous echoes with membranous echoes with the retina attached. This is the fundus picture. This is a post-op fundus picture. He underwent vitrectomy with intravitreal vancomycin plus ceftazidime and dexamethasone. Vitreous biopsy showed a positive culture for methicillin-resistant Staphylococcus epidermidis. This is the exudate foci in the vitreous. Post-op day 7 of fundus.
A short overview on HLA-B27 associated uveitis, which is a common mimicker of endophthalmitis. So hyperacute symptoms with very severe fibrinous uveitis with hypopion, with severe vitritis often mimics endophthalmitis. So these are various case reports and case series where very severe HLA-B27 associated pan-uveitis has been noted to mimic as endophthalmitis. So in our in-house study on ocular manifestations of HLA-B27 associated uveitis, 4% cases were noted to have intermediate uveitis along with anterior uveitis in such cases. So the prognosis of HLA-B27 associated uveitis is usually favorable, but it has been reported that 11% of these cases can become legally blind in the affected eye. So it is important to diagnose and manage correctly. So to conclude, meticulous history taking is the key to differentiate in most of the cases. Do not miss the leading signs of endophthalmitis. When in doubt, do not inject intravitreal or periocular steroid or give high dose of steroid. Order blood culture and urine culture whenever investigating for uveitis. Avoid over investigating for uveitis like doing HRCT chest or PET CT to reduce the financial burden. And always it is better to err on the side of infection whenever in doubt. Thank you.
Just one comment. Except for the last case, we were all left wondering whether the clinical suspicion was correct or wrong. Correct? Because you said patient was taken up for lensectomy and vitrectomy. So what happened? And when patient has lymphoma, do you want to do cytology of the specimen? Right? So a little bit more, I appreciate that the cases you chose were very nice, where it's a question of is it this or is it that. But I'm sure all of us were wondering what actually happened to the patient.
Lost to follow-up.
Yeah.
Patient was lost
to follow-up.
No, then you mentioned it is lost to follow-up. Because you it's leaving, now like Meena said, you gave intracameral moxifloxacin. What happened to the patient? Did he get better? Did he not get better? Because I agree that the clinical finding was little atypical for an endophthalmitis. It could be because so much steroid the patient was getting, it dampened the whole thing. You have a patient with systemic lymphoma coming with some exudates in the vitreous. Yes, endophthalmitis is there, but you also want to do cytology of the sample. Right? So things like that. Otherwise, presentation is very nice, but it would have been nice if all those stories had a little bit of ending.
Good evening, everyone. We'll be discussing endogenous endophthalmitis, how to investigate. Endogenous endophthalmitis is a rare vision-threatening intraocular infection that arises from the hematogenous spread of microorganisms from a distant source. It is essential to preliminarily rule out a previous history of eye trauma or surgery. It has a poor visual prognosis and often leads to blindness, phthisis, or evisceration. The associated septicemia may be life-threatening with a mortality rate of 5 to 15%. Its management encompasses the treatment of the eye disease as well as a search for the source of infection. The common associated risk factors include a history of recent hospitalization, diabetes, urinary tract infection, history of malignancy, HIV, neutropenia, IV drug abuse, long-term indwelling catheters, and chronic immunosuppression. It may also be associated with a liver abscess, usually Klebsiella pneumoniae, and also the presence of associated diabetes is a major risk factor and has a higher incidence in Asian countries. It may also be associated with an infective endocarditis and even a case of a simple transient bacteremia such as post-colonoscopy or a recent dental extraction. In the Western countries, gram-positive bacteria have been noted to be more common, while in the East Asian countries, gram-negative bacteria are more commonly isolated. Coming to fungal endophthalmitis, yeast-associated endogenous endoph is more commonly associated with a history of chemotherapy or a history of solid organ transplantation, commonly the heart or liver, while mold-associated endogenous endoph may have a history of immunomodulatory treatment, especially stem cell transplant and pulmonary aspergillosis. Citing this in-house study on endogenous endophthalmitis, it was published in the Asia Pacific Journal of Ophthalmology, and it evaluated 61 eyes of 58 patients with endogenous endophthalmitis. The associated systemic ailments among the patients were studied, and no associated systemic conditions were seen in 46.5% of the cases, while 37.9% had associated medical conditions, in some cases more than one systemic condition. The most common one was diabetes, and this was followed by enteric fever, chronic renal failure, UTI, TB, septicemia, and one patient each with a history of meningitis, diarrhea, AIDS, hepatitis B, gastroparesis, cirrhosis, fungal infection, and mitral regurgitation. 15.5% patients had a history of recent surgical intervention, out of which 10% had a history of abdominal surgery. Others included appendectomy, total gastrectomy, even a history of cesarean delivery, genitourinary surgery, urinary lithotripsy, surgical termination of pregnancy, head and neck surgery, and tooth extraction. A positive culture from either the aqueous or other body fluids was obtained in 34 patients, that is 58.6% of cases. The vitreous was positive in 27.6% and aqueous in 18.9%. The most common isolated organism was Pseudomonas aeruginosa in a total of 8 cases, 3 from the aqueous and 5 from the vitreous. The in vitro antimicrobial sensitivity was evaluated, and it was found that 100% cases of Pseudomonas were sensitive to ciprofloxacin and amikacin, while all the cases of Staphylococcus were sensitive to vancomycin. Neonatal endogenous endophthalmitis. It is an alarming and potentially fatal condition due to associated candidemia and bacteremia. It may be associated with a risk factor of retinopathy of prematurity and low birth weight. The commonly associated organisms include streptococci, especially Agalactiae, Klebsiella, Pseudomonas, and Candida. Coming to pediatric endogenous endophthalmitis, it is quite rare and has an incidence of only 0.1 to 4% of all cases of endoph, with the highest incidence being reported in India. It may present quite differently as compared to adults, and often there is a delayed presentation with variable systemic features, malnourishment and impaired immunological status, and a lack of established guidelines for its management, which further confound this condition. Quoting this study by Mehta et al., in endogenous endophthalmitis in children and adolescents, it evaluated 30 children, out of which all the children presented with severe AC reaction and vitritis, and 2/3 of the children had a yellow glow with no visible fundus details. Investigative procedures, the vitreous yielded positive results in 23 cases or 76.7%, which included a positive vitreous culture in 66%, a positive PCR in 3%, and IgM antibody for Toxocara in 6.7%. A blood and urine culture was done for all the children. However, only 2 cases were positive for urine culture and none had a positive blood culture. Among children, the most commonly isolated organism, it was the serum IgM for Toxocara in 7 children as opposed to adults. The underlying systemic infection was only noted in a few children, history of fever in 4 children, and pneumonia and diarrhea in 1 child each. They also evaluated a univariate analysis of possible factors which may lead to a favorable functional outcome. It was found that no single factor had an eventual positive outcome, irrespective of the gram staining, associated systemic illness, whether systemic steroids were used or not, the type of organism, or the media clarity. None of these factors eventually had a statistically significant positive outcome. The diagnostic workup for a suspected case of endogenous endophthalmitis is required to be done systemically and includes an amalgamation of tests, including from the ocular fluid, vitreous or aqueous, gram stain and culture, fungal stain and culture, a PCR if indicated for HSV 1 and 2, VZV, CMV, and toxoplasma. Blood tests include bacterial culture, fungal culture, a complete blood count with differential, the blood chemistries including liver function tests, and tests for specific systemic infections and inflammation, that is to rule out HIV, toxoplasma, hepatitis C, angiotensin converting enzyme for sarcoidosis, ESR, syphilis, quantiferon TB gold, Lyme serology, and a beta-D-glucan assay or galactomannan assay for fungi. Other laboratory tests include urine culture and, if required, a CSF culture and a Mantoux test. Imaging includes a B-scan ultrasound, echocardiogram, chest X-ray, MRI of brain and orbits, and an ultrasound of right upper quadrant. Galactomannan testing. Fungal culture is a time-consuming test with a low positive rate, and this often leads to delays in the diagnosis and management. The evolution of galactomannan testing has been started to overcome this problem. Galactomannan is a polysaccharide antigen that exists primarily in the cell walls of Aspergillus species. It may be released into the blood and other body fluids like the bronchoalveolar lavage fluid, and ocular fluid even in the early stages of Aspergillus invasion. Therefore, the detection of the antigen level can be useful to make an early diagnosis of aspergillosis. Yu et al. Analyzed the galactomannan in intraocular fluid samples of various intraocular infections. In a paper by Yu et al., they analyzed the galactomannan levels in intraocular fluid samples of various intraocular infections, and they found that they were able to rapidly identify the cases of Aspergillus endoph and also start a definitive treatment and eventually lead to a better prognosis, and it is also a good marker of therapeutic response. Beta-D-glucan testing. Beta-D-glucan is an abundant cell wall polysaccharide that is found in most fungi. It is present at detectable levels in various fungal species including Candida, Aspergillus, Pneumocystis, Fusarium, Trichosporon, Histoplasma, etc. These fungi release sufficient amounts of beta-D-glucan into the bloodstream that allow it to be reliably detected by the assays. Overall, several studies have been done, but they have not demonstrated any significant difference between beta-D-glucan level and galactomannan in diagnosing infections caused by Candida and Aspergillus. Coming to the use of PET-CT in infectious diseases, it is helpful to detect occult infections, as whole body imaging helps to locate infections which may not be visible on conventional imaging. It helps to assess the extent of disease and is critical in cases of disseminated infections like TB and fungal infections, and assesses the multi-organ involvement. It is also useful to monitor treatment response. It helps to identify infected prostheses and devices like valves, grafts, pacemakers, and orthopedic implants, and also helps to guide biopsy and other interventions. It does come with its set of limitations. FDG has a low specificity and therefore it can hinder the differentiation between pathologic and physiological uptake, especially in the brain, liver, myocardium, and bladder. Also, it cannot definitively differentiate infection from an aseptic inflammation. It may produce false positives post-surgery or during inflammation, as in rheumatoid arthritis, and is quite expensive and has a limited availability. Recently, the PET MRI has also been introduced, which may be more effective in identifying infectious sources. Infections where PET-CT is helpful in cases of TB, endocarditis, osteomyelitis, fungal infections, and HIV-associated infections. Some newer radiopharmaceuticals have been introduced for infection tracing, which are still under study. A brief word about voriconazole therapeutic drug monitoring. It may be done on the 5th day after the starting of the treatment. It may be initiated earlier in patients with aggravation of clinical symptoms or those who develop features of hepatotoxicity. This is measured using either the liquid chromatography tandem mass spectroscopy or high performance liquid chromatography.
Good evening, everyone. Namitha has told us about the systemic investigations in case of endogenous endophthalmitis. I will give a brief about ocular investigation in case of endogenous endophthalmitis. So system ensign, as we all know, edema, circumcorneal congestion, corneal edema, hypopyon, SE cell flare, iris nodules, and absent red. Bilateral involvement and scleral involvement can be seen in case of Mycobacterium tuberculosis. Endogenous endophthalmitis caused by Candida can present as vitritis or fluffy white retinal lesions extending into the vitreous. Aspergillus can present as a yellow or white lesions which can be focal or diffuse. If the media clarity permits, retinal hemorrhage and cotton wool spots may be visualized. Severe vitreal involvement in bacterial endogenous endophthalmitis can present with a subretinal or choroidal abscess. Retinal detachment in case of delayed presentation of methicillin-resistant Staphylococcus aureus associated endophthalmitis. So, the investigations and ocular and systemic investigation should be side by side and not first ocular and then systemic. Indication of aqueous step. Indication in cases with severe anti-uveitis or hypopyon, where vitreous involvement is minimal. Media opacity, where vitreous sample is not visible. Advantages of aqueous step is it is simple, quick and office-based procedure, minimal risk compared to vitreous step. Limitation of aqueous step is lower yield than vitreous in endogenous endophthalmitis, may miss pathogen in posterior segment infection. Advantages of vitreous step is higher yield than tape can be combined with immediate intravitreal injection or followed by complete vitrectomy if needed. Limitations of vitreous tape is more invasive, requires OT setup and risk of bleeding, retinal detachment and hypotonia. So this is the comparison of aqueous tape and vitreous tape. Sample is aqueous humor, vitreous humor. Location we do it from limbus, whereas vitreous tape is done from pars plana root. Needle 27 to 30 gauge needle, where vitreous tape is 23 to 25 gauge needle. Sample volume 0.1 to 0.2 ml in case of AC tape and vitreous tape 0.2 to 0.3 ml. Gram stain, KO stain, culture, PCR and cytology in both vitreous tape and AC tape. Sensitivity is 20 to 30%, while vitreous tape is higher sensitivity 50 to 70%. So this is the photo. PCR. PCR is indicated in case where negative culture is negative and we have high suspicion of infection. Pre-treated cases for fastidious or rare organism and where early treatment is crucial. Sample is aqueous, vitreous, blood or any body fluid. Advantages of PCR is it is objective test. Gram and KH staining are operator dependent tests. Rapid, it takes culture takes 48 to 72 hours, while it is done PCR is mainly done in 8 hours. Sensitive test, sensitivity for bacteria is 85 to 90%, while fungi is 70 to 80%. Effective in prior treated cases also. Limitations of PCR is its drug sensitivity and resistant pattern cannot be detected with PCR. It is more expensive, not available in all the centers. False positivity due to contamination if sample is not handled with care. False negative due to inhibitors or low sample volume. So this is the PCR pattern. Next is the USG-B scan. USG-B scan helps in evaluating posterior segment structures non-invasively in cases of media eyes due to corneal edema, fibrin in AC, hypopyon or dense vitritis. Key USG finding in case of endogenous endophthalmitis is low to moderate reflective dot echoes in the vitreous cavity which are mobile, which suggests a dense vitritis. Mobile membranous echo in vitreous cavity which suggests exudate, fungal balls or fibrin strands. Retinochoroidal complex thickening in severe cases. Subhyaloid dot echoes is seen in case of fungal infection like Candida or Aspergillus. Choroidal elevation, choroidal abscess or choroidal elevation suggests choroidal abscess or subretinal exudation. And in complication, retinal detachment can also happen. How we can identify fungal versus bacterial in case of B scan? So, fungal endogenous endophthalmitis has multiple discrete opacity of balls, while bacterial endogenous endophthalmitis has more diffuse homogeneous echoes. Location of echoes is more posteriorly as subretinal or subhyaloid in case of fungal endogenous endophthalmitis, while it is throughout the vitreous cavity in case of bacterial. Response to treatment is slower in fungal, while it is rapid in case of bacterial endogenous endophthalmitis. Role of serial USG-B scan to monitor the response to treatment and evaluate the complication like worsening of vitritis, retinal detachment or choroidal detachment. So this is the USG-B scan which shows the multiple mobile vit echoes and with posterior vitreous detachment and subhyaloid dot echoes are also seen. So this case is showing the T sign which helps in differentiating endogenous endophthalmitis from anophthalmitis. Choroidal biopsy in endogenous endophthalmitis. It's a specialized and rarely used diagnostic.
Looking at ultrasound, little more description obviously we'll need. You just describe, you are talking about fungus and bacterial was Partho. I can hear is telling posterior echoes, mid-vitreous cavity, anterior echoes. Do you want to describe on your ultrasound what is suspicion? Obviously, nobody is going to say that looking at ultrasound this is fungal or bacterial. You always correlate clinically.
Yes, sir.
A little bit when you talk this thing, this is ophthalmic part. I think this is what you should be elaborating more, not just passing remark.
Yes, sir. Yes.
Can you describe the ultrasound a little better way?
Like this ultrasound in the description or there is no definite lens echo which is noted. In vitreous cavity there is a multiple mobile means mobile we cannot tell in this image. It is a kinetic USG finding. Multiple mobile dot echoes with low reflectivity, low to moderate reflectivity is seen in vitreous cavity. diffuse choroidal thickening is seen, and widening of the subtenon space with which is continuing at the optic nerve. So this is a T sign, and optic nerve had ONH echo is normal. ONH echo is normal. So, talking about choroidal biopsy in case of endogenous endophthalmitis, it's a specialized and rarely used diagnostic tool, and endogenous endophthalmitis typically reserved for challenging cases where conventional method fail to identify the pathogen. Indicated in case of suspicion of choroidal abscess, which is more common in case of tuberculosis and Klebsiella or mass lesion, persistent inflammation despite treatment, and negative culture or PCR from aqueous or vitreous. In this choroidal, this USG B scan is showing no definite lens echo with multiple homogeneous mobile vitreous echoes, low reflective vitreous echo with membranous echo, and choroidal mass lesion is seen, and with retinochoroidal thickness cannot be much commented upon in this case. So we do choroidal biopsy for this type of cases. Techniques of choroidal biopsy is transvitreal or fine needle aspiration biopsy. Transvitreal is done via pars plana route. After core vitrectomy, a small incision is made in the retina to assess the underlying choroid. A retinal forceps is used to obtain the tissue. Fine needle aspiration biopsy is done in selected anteriorly located choroidal lesions. 25 to 30 gauge needle is passed through the sclera under USG or indirect ophthalmoscopy guidance. Less invasive but limited tissue yield. Risk and complication associated with choroidal biopsy is retinal detachment, subretinal hemorrhage, intraocular hemorrhage, worsening of infection, and scar formation. Tissue is sent for histopathology, Gram-stain, QH, AFB, and culture and PCR. Also helps in distinguishing between the infective, inflammatory, or neoplastic causes.
Good evening, everyone. Our topic is clinical evaluation of infectious endophthalmitis, bacterial versus fungal, outpatient investigations. So, starting with the clinical spectrum, endophthalmitis is the suppurative inflammation of the intraocular fluids involving the vitreous and the aqueous humor. Progressing further can be panophthalmitis, which involves the sclera, orbital, and the periorbital tissue in addition. Preseptal cellulitis is involving the skin and the soft tissue infection anterior to the orbital septum, and breaching that is the orbital cellulitis. So briefly the classification, it is exogenous and endogenous. Exogenous is post-traumatic and post-operative. Post-operative being the most common. In post-operative, it can be post-cataract, which can be acute and chronic, then post-penetrating keratoplasty, bleb-related, and post-intravitreal injection-related. So before we go further, it's important to differentiate between toxic anterior segment syndrome and endophthalmitis. Pathogenesis is the inflammatory reaction to various products used in surgery or IOL related. Endophthalmitis is intraocular colonization of microbial agents with associated inflammatory reaction. The history is usually it presents within less than 48 hours, and endophthalmitis could be even within 48 hours and 3 to 7 days later. Pain is usually uncommon and is characteristic in endophthalmitis. On examination, the visual acuity in TAS is mild to severely reduced. There is limbus to limbus corneal edema. There is presence of fibrin, and hypopyon may be present, while the color of exudates is a little whiter in TAS and more yellow in endophthalmitis. Focal infiltrate is usually absent and present in endophthalmitis and absent in TAS. These cells are present higher grade in endophthalmitis and lower in TAS. The IOP is usually normal and commonly elevated in endophthalmitis. The posterior segment involvement, which is the vitritis, is mostly absent in TAS, and USG is anechoic, while the vit echos are clearly present when it is endophthalmitis. In management, it dramatically responds to steroids, while endoph responds to antimicrobial agents and has a poorer prognosis, while TAS has a good prognosis. So common symptoms, as already discussed, are redness, vision loss, swelling, and pain. Moving on to the clinical evaluation, we must start from anterior to posterior. Lid and adnexa, which are more common for traumatic endophthalmitis. Extraocular movement assessment, this is important to differentiate with the panophthalmitis in which they are reduced. Vision, projection of rays and perception of light status has to be noted. Intraocular pressure depending on case, whether digitally or with applanation tonometry. Pupil assessment. Briefly, the anterior segment findings, like in bacterial, it can be discharge, matting of eyelashes, and digital tenderness. Conjunctiva can have chemosis, diffuse and circumciliary congestion. Sclera can have abscess, and we must examine the wound or the surgical site which had led to the endophthalmitis. In cornea, epithelial defect, corneal edema, infiltrates, entry site infection, any wound dehiscence which is present post-operative, presence of loose sutures, suture abscess, limbal ring abscess, and keratic precipitates on the endothelium. Anterior chamber can have hypopyon, cells, and flare. Assessment has to be done. Iris involves loss of pattern and can be boggy and muddy in texture. Posterior synechiae, peripheral anterior synechiae, iris nodules, fibrin membranes or the pupillary membrane, iris prolapse in case of laceration if present, and usually such are resistant to dilatation. Lens status has to be noted, whether it is aphakic, and if there is presence of IOL, whether exudates are present over the IOL, posterior capsule status, presence of a plaque, and in case of trauma, intraocular foreign body or surface foreign body. So these anterior segment slit lamp examination photos are there. In first photo, we can see there is collection of abscess around the intraocular lens with corneal edema, conjunctival congestion. In the second picture, we can see the suture infiltrates are present inferiorly, and collection of suture-related abscess can be seen. And in the last picture, we can see a trace hypopyon inferiorly, posterior synechiae, presence of cells and flare, but not examined on this diffuse illumination, and resistant to dilatation, that the pupil cannot be dilated. Moving on to the fundus evaluation, in early or mild cases, the red reflex may be present. Some retinal details like the disc or the vessels can be seen. In advance, there would be yellow or no glow. Vitreous haze would be present due to the exudates. There's EVS grading for noting down the vitreous haze. Grade 1 is more than 20/40 view of the retina. The disc and the vessels clearly visible. Grade 2 is second order retinal vessels visible, and grade 3 is some vessel visible but not the second order. And grade 4, no vessels are visible, only red reflex is present, and even that is gone in grade 5. So this is an image showing vitreous haze in which second order retinal vessels are visible but not beyond that.
So coming on to bacterial and fungal endophthalmitis, most common organism that we see in acute post-cataract surgery endophthalmitis are coagulase negative staphylococci, almost around 70%. Then Propionibacterium acnes is seen in subacute post-cataract surgery endophthalmitis. Post-injection, we see mostly coagulase negative staphylococci, and bleb-related endophthalmitis are usually caused by streptococci. Post-traumatic is mostly due to Bacillus cereus, and chronic post-operative fungal endophthalmitis are mostly due to Aspergillus. So, a very characteristic feature of Propionibacterium acnes is a whitish plaque that we see in relation to capsular bag, and it has a tendency to relapse. Bacillus cereus is mostly seen in the setting of a trauma, and it has orbital pain and proptosis with a characteristic ring-like infiltrate or abscess, and along with systemically, patient can present with fever along with leukocytosis. There was a study conducted by Das and his associates across 7 centers of India, where they found out that fungal endophthalmitis was around 19%, and the most common etiology being post-surgery, followed by the trauma, and the most common organism isolated was Aspergillus. This is the table differentiating bacterial and fungal, although the presentation may vary, but mostly when it presents acutely within days of inciting event, it's more of a bacterial cause. And fungal has a subacute presentation with the worsening over a course of days to weeks. Vision loss can be rapid and severe in case of bacterial and gradual in fungal. Anterior segment involvement with the matting of lashes, discharge, crusting, excessive watering and photophobia along with blepharospasm is in mostly bacterial. Fungal, these particularly may be absent, but it's not absolute. So hypopyon is often present and mobile in case of bacterial. Fungal, it can be there and quite fixed. It will not be as mobile as in bacterial. IOP is variable in case of bacterial, but mostly high in case of fungal. Vitreous inflammation is there mostly in the bacterial, and in case of fungal, we see clumps or snowballs in the vitreous cavity, and fungal ball is a classic feature. Retinal and choroidal lesions are mostly seen in fungal endophthalmitis. If the view is very clear, we can actually see fluffy white focal areas of chorioretinal lesions with overlying vitritis or cotton balls, which may be suspended in the vitreous, giving a string of pearls appearance, which is very specific for candida. Confluent yellowish infiltrate can be seen in macular area, which beginning in the choroid or the subretinal space, along with retinal hemorrhages, vascular occlusions, or full thickness retinal necrosis, as seen in endophthalmitis caused by aspergillus. Steroids have hardly any role in fungal endophthalmitis, but they are used to control the inflammatory component of the bacterial endophthalmitis. So coming on to the anterior segment investigations, mostly we do slit lamp photo, anterior segment OCT, and ultrasound biomicroscopy. So this is a slit lamp photo. The first picture is a post-cataract surgery endophthalmitis caused by gram-negative bacilli. It was a serratia organism. So it shows corneal infiltrates with superiorly, suture looks a bit loose, and there are exudates in the AC with a very hazy view of the fundus. So ultrasound was done which showed Viticos. The second picture is a post-penetrating keratoplasty fungal endophthalmitis. It was a Candida species, and here the ultrasound shows multiple Viticos with choroidal thickening.
What's the role of slit lamp photography in this patient? I mean, why do we do it?
So slit lamp photographs can be used to monitor and document the anterior segment, and we can see the progression or regression with time. Then coming to the role of anterior segment OCT, it is used to tell about the depth of corneal infection, whether in case of trauma, whether the corneal laceration is self-sealing or not, to confirm it, and cataract wound architecture or the presence of retrocorneal exudates or hypopyon. In the first top right picture, here we can see there are 3 hyper-reflective dots over the endothelium, signifying KPs here, keratic precipitates. This was a case of post-ICL fungal endophthalmitis due to aspergillus species. The right down picture, here it shows a fibrin membrane which is communicating to the surgical wound, and the fibrin membrane communicating to the surgical wound and the lens posteriorly. And in the bottom left picture, we can see there's a hypopyon and an exudate over the iris surface. Here we can see this is the hypopyon, and this is the exudate over the iris surface. This is that fibrin membrane which is communicating between the section and the lens, and these are the 3 hyperreflective dots. Then role of UBM in endophthalmitis to detect a PC plaque or inflammatory debris within the capsular bag, to differentiate endophthalmitis from chronic postoperative inflammation by detecting the IOL position and its relationship to the ocular tissues around, and to look for any cause of hypotony like ciliary body cleft, dialysis, cyclitic or pars plana membranes, location of foreign body in case of traumatic endophthalmitis. These are certain pictures depicting peripheral anterior synechia as seen here in the first 2 pictures, and thin pars plana membranes. These are the pars plana membranes, and those are the peripheral anterior synechia that we see. This is the in-house publication which shows the presence of foreign body being detected on UBM. So the first picture shows an intralenticular foreign body. The second picture shows a foreign body in the anterior chamber. The third is the foreign body in the pars plana region. The fourth image, this is the foreign body in the pupillary area, and here it is present behind the iris in the retroiridal space, and this is in the iris stroma, actually, the foreign body inside the iris stroma, and this is the caterpillar hair which is projecting into the AC. So investigations in when the fundus view is clear is mainly the optos or the color fundus photograph, and we can do OCT to find the level of the lesion. And when the view is poor, then we use ultrasound or CT scan to look for the foreign bodies. So this is an optos picture. The first picture shows the exudates in the post-cataract surgery endophthalmitis, which came out to be Eubacterium positive. The second is the fungal endophthalmitis due to Candida albicans, showing a characteristic string of pearls appearance. Then this is an OCT which was done for a surface nodule where fungal endophthalmitis was being suspected. So this shows a characteristic rain cloud sign where we see fungal colonies which appear as bright and white, highly reflective spots on the OCT located on the retinal surface or within the vitreous, with backshadowing due to the light being blocked by the fungal mass. This is the ultrasound showing the first picture shows the dot echos are the first to begin with, then they organize to form the clumps and then the membranes in the vitreous cavity. Then further deterioration maybe can present with a retinal detachment as seen in the second picture. And then if the endophthalmitis progresses to involve the sclera and there is widening of the subtenon space, then we may see it as a T sign and diagnose it as panophthalmitis. Here we can see in the first picture there's choroidal thickening. Then the second picture shows a serous choroidal detachment. And in cases of trauma, we can also see the ocular wall discontinuity as seen here in the third picture. Role of CT imaging is mainly to see for the abnormal echoes of signal densities from the vitreous, if at all, and uveoscleral smooth or irregular thickening can be seen with enhancement. Here we had a case where the patient had suffered an electric board blast injury and had anterior segment and posterior segment foreign bodies seen on CT scan, and the similar could be replicated on the ultrasound pictures as well. And the right top corner is a 3D construction of CT scan showing a similar foreign body. So the take-home message being that endophthalmitis is mostly a clinical diagnosis, but ancillary investigations like ASOCT, slit lamp photo, and UBM can act as an additional tool in monitoring and guiding treatment. Ultrasound B scan is used for the assessment of posterior segment in case there is poor view of the fundus. Thank you. These are my acknowledgements.